Hello, everyone, and welcome to this workshop on health risk factors and inequalities in the European Union. We will give you insights from the Global Burden of Disease study on these important and urgent questions during this workshop. My name is Brecht de Vleeschouwer. I'm an epidemiologist at CNSANO, the Belgian Institute for Health. I'm also the chair of the European Burden of Disease Network, and it's my pleasure to welcome you and our speakers to this workshop today. This workshop is an activity organized within the context of the European Burden of Disease Network, which is a group of close to 300 people from across Europe and beyond who have an interest in burden of disease, in the use of DALYs, disability-adjusted life years, to quantify health impact of diseases and risk factors. We aim to serve as a technical platform to integrate and strengthen capacity in this methodology in burden of disease assessment across Europe and beyond. And it's in this context that we are organizing a number of workshops during this European Public Health Conference. In this workshop today, we will show you how the estimates of the global burden of disease study can be used to obtain comprehensive and comparable estimates of population health impacts of diseases, injuries, risk factors, but also inequalities. Our presenters will give you a picture of the state of health in the European Union, including information on the main causes of ill health, the main contributing risk factors, and the prevailing health inequalities today in Europe. We will have two presenters who will give you a series of three presentations. First, we will have João Vasco Santos, who will talk about the state of health in the European Union in 2019, and will also talk about the burden attributable to risk factors in the European Union. And João is a public health medical doctor at the Northern Regional Health Administration and also the University of Porto in Portugal. His research focuses on health systems and policies, and he's currently also serving as Vice President of the UFA Public Health Economics section. Our second speaker will show you new results on inequalities in non-communicable diseases across the European Union, looking at current states, but also trends in the past 2 decades. So this will be José Luis Peñalvo, who is an epidemiologist, head of the unit of non-communicable diseases at the Institute of Tropical Medicine in Antwerp, Belgium, and also professor of chronic disease epidemiology at the University of Antwerp in Belgium. His research focuses on modeling the effects of population-based strategies to reduce NCD-related burden, including synergies with infectious diseases and with a particular focus on vulnerable groups. After each presentation, there will be time for some questions and answers. Feel free to add your questions to the Q&A section with a mention of the name of the speaker so that we know who your question is directed at. So without further ado, I want to give the floor to João to give us his insights on the state of health in the EU in 2019.
Thank you so much, Bert. Thank you so much for the introduction. So as you said, I will present the state of health in the European Union in 2019. It was quite a collaborative work that we have done together within the European Burden of Disease Network, and we expect to have these papers published soon. As Bert said, any further questions, please use the Q&A and let me know. So, as you know, the European Union is currently facing many challenges. So, not only population aging, but also the new ways and new models of organizing health systems, mainly after all this impact that COVID-19 had. Nevertheless, I will present estimates for 2019. So 2 years ago, when nothing of this COVID-19 pandemic had happened. However, I also have to say that this is quite a continuous work. So we had previously published the State of Health in the European Union in 2017 in the European Journal of Public Health, and as well of the enlargement effects in the European Union health in the International Journal of Public Health. So please feel free to look at both papers that are already published and to get in touch with us. So, however, I also have to say that comparing to the 2017 estimates, this new study, the new global burden of disease study, the 2019 study, had some improvements. So mainly with the improvements of health outcomes over time that we had previously showed in the 2017 estimates. But also the heterogeneity of EU countries. We had showed this before in the 2017 papers. And now, as I was saying, these new improvements from the GBD study of 2019 that came were key demographic modeling steps, measurement methods, and the improvement and the updating of the meta regression tool that GBD is using, and additional data sources, and actually 12 new causes were added to the full list of causes that were already in the 2017 study. So our aim here was to analyze the GBD19 study estimates in order to describe its health status in the EU, focusing on the several estimates that GBD actually produces. And comparing the 2019 status with the 2010 status of the European Union. So we have done this study, this ecological study, considering the 28 countries of the former European Union, as I said, between 2010 to 2019. And I must highlight that the GBD19 2019 study considers 286 causes of death, but actually 369 diseases and injuries. So some of them won't and don't cause death, as you might know. And we have analyzed prevalences, incidence, mortalities, YLDs, YLLs, dailies, life expectancies, including healthy life expectancy. I will tell you a bit more further on. And I must say that the study also considers the cause fractions and calculated using the cause of death ensemble model and spatial temporal Gaussian process regression. So as you know, dailies are the sum of YLLs and YLDs, meaning years of life loss and years lived with disability. So years of life loss are calculated by multiplying the number of deaths by the standard remaining life expectancy. So the standard life expectancies, they are actually present in the GBD standard population and standard life table. And the YLDs are calculated by multiplying the prevalence by the disability weights. Here we present the estimates, but also the 95% uncertainty intervals, and we focus mainly on the age standardized rates of dailies for the 22 level 2 causes. So there are several levels in this specific level of causes of death. There are 22 causes which were analyzed and compared. So compared to 2010 and compared between countries as well. And to compare longitudinally, we have calculated the relative change between 2010 and 2019 to get it. So in this graph, you can see both YLL in yellow, in yellow, sorry, and YLD and in the blue part, and you can see that of course with those higher age groups, also have higher dailies. And here I just like to state that currently, of course, in 2019, the EU presented 5.35 million deaths, more than 150 millions of dailies, and had overall, so at average, the EU at average, 81 years of life expectancy. And regarding healthy life expectancy, the estimate was 69.8. I just would like to highlight that in the left side of the screen you have the females, and in the right side you have the males, and you can see the different patterns, and you can see also the uncertainty interval. In this figure, you can see that in the x-axis you have the age standardized YLL, while in the y-axis you have the YLD rates. Actually, the bubble size is the age standardized daily rate. So you can see that, for instance, the most impacting on burden of diseases causes are mental disorders and musculoskeletal disorders, but mainly through the YLD effect, while in cardiovascular diseases and neoplasms, although they also have a quite great impact on the burden of disease and on dailies, these are mainly due to YLLs instead. So here you can see this table comparing all the countries and all the EU countries for these 22 level 2 causes with the EU 28 average. So you can see, so this is ranked, and you can see that Bulgaria is in the bottom, and Spain in the top. And however, you can see here in the red cells those that are those estimates that are statistically significantly lower in terms of the red, and the opposite in terms of the green cell. So you can see here, for instance, that Spain has actually a higher number of age standardized daily rate compared to the EU regarding the HIV, AIDS, and sexually transmitted infections. And in the opposite side, for instance, you can see that Romania had a lower estimate comparing to the EU on substance use disorders regarding daily rates. Of course, that we can see here pattern specifically on cardiovascular diseases, for instance, but also on self-harm and transport injuries. And this is quite related to the overall rank that the countries have here. In this figure, you can see the change from 2010 and 2019 in Europe. And you can see that there are no clear increases in both YLL and YLD. So you see that the quadrant, the first one, is not populated. Instead, the third one is well populated, and you can see that for instance, transport injuries are quite improving, I would say, both in terms of YLLs and in terms of YLDs. Of course, we are talking about age standardized rates, and you can see here this value. However, I have to highlight that diabetes is instead increasing in terms of YLDs, and actually in terms of dailies, it was the only level 2 cause with a small increase in the European Union 28 comparing to 2010 with 2019. So overall, there is a decrease on both actually death and these should be daily rates, sorry. So 5.8% decrease on daily rates, and a 1.8% increase of life expectancy, 1.2% increase of healthy life expectancy. Actually, we can see also the range from Bulgaria to Spain in both life expectancies between 73 and 83. So we can see a 10-year range, while we can see for the healthy life expectancy a range of about 7 years, also for the same countries in the top and the bottom positions. So in conclusions, we can still say that cardiovascular neoplasms account for most of the burden in EU in 2019. We can still see, as you saw in that ranking, that the East-West burden of disease gap still persists, and however, there are important improvements. We saw, for instance, transport injuries. However, I must also highlight that diabetes is an increasing concern for the European Union. Some limitations, of course, of the GBD approach. We are using, actually, GBD study uses the same disability weights and same severity distributions for all the countries. And of course, it relies on the mobility data and its quality. So for future work, everyone is welcome to work on specific diseases or specific countries, and we should work together to fight these diseases and to improve health systems together. And there is a clear need of improving health information systems, and we believe that European Health Data Space can be an opportunity to do so. And that's it from me.
Yeah, thanks a lot, Joe, for these very important and interesting insights. I'm looking at the Q&A to see if there are any questions at the moment. Not yet seeing any. If not, maybe if I can ask you a question, what do you think would be the impact of COVID in 2020, 21 on the picture that you have painted here now?
I believe that COVID-19 will have a lot of impact mainly on YLLs, but of course that you also know that the disability weight for COVID-19 is still being discussed, and there are still a lot to do on that, and we'll see what will happen in terms of dailies attributed to COVID-19, but I really believe that it will take a lead, at least in the respiratory disease, I'd say. Yeah.
Okay, thanks. And we're indeed looking forward to the release of the GBD 2020 estimates later this year, if all goes well. I also see a question popping up now. What do you think the impact would be if country-specific severity distributions were used for the YLD estimate? Also linked to the fact that YLL still constitutes, maybe in a number of countries, the majority of DALYs.
Yeah, I believe it depends a lot, and it depends a lot on how the disability weights are built on. So if we are talking about the same disability weights that the GBD is using, probably will have an important impact. But if we would think in other ways of doing so, for instance, using different kinds of quality of life measures, we would have even a higher impact on that, because as we know, there are cultural differences, and different countries consider and actually think about health in different ways. So probably if we are considering different measures of disability weights, that the impact will be even higher. Yeah.
Okay, thanks a lot. So I suggest we can then move on to the second presentation of the workshop, which will also be provided by yourself. But there you will zoom in on the risk factors, which is of course very policy relevant, because it's on the risk factors that we can act. So we're very much looking forward to your insights on the burden attributable to risk factors in the EU. So
thank you so much,
thanks, and feel free to take the floor again.
Thank you so much, and thank you for the two questions as well of the other presentation. So regarding this, the part of the risk factors, I would like to highlight that this is an ongoing process, and we had already published actually quite recently in the October issue of the European Journal of Public Health this paper on risk factors, and we showed a decrease in risk factors attributable burden and as well a great heterogeneity between EU countries. And we see, of course, we know that non-communicable diseases are still the leading cause, as you saw in the last presentation. We had cardiovascular diseases, neoplasms, and mental disorders, for instance, leading these causes, and these can be tackled, of course, through behavioral interventions, and through, again, new organization, new models of health systems. We know, for instance, that regarding cancer, there is the European Beating Cancer Plan. So there is a lot and new efforts coming up. So comparing to 2017, the 2019 also showed improvements on the risk factors part. So there were revised corrections for non-reference method exposure measurements. Also, the high and low non-optimal temperatures were included as new risk factors, and the dose response meta regressions were also improved. So here we intended to analyze the impact of risk factors on the state of health and these estimates that I talked before. So same estimates. However, here we are considering 87 risk factors, but the same methods as well. So how are risk factors calculated? So first, risk outcome pairs are produced using and reviewing a lot of literature and getting like meta analysis on this literature. Then relative risks and as a function of exposure are also calculated in the same basis. Levels of exposure in each sex location here are produced based on the data that is collected throughout the countries. And then there is a theoretical minimum risk exposure level, which is calculated considering all the countries globally. Afterwards, there is the computation of the mortality and dailies through path, and then adjusting these to a mediation of different risk factors. So again, we presented estimates including uncertainty intervals. We presented mainly death and daily rates, and as well the summary exposure values, and as well use the same longitudinal approach. So we can say now that in 2019 for the European Union 28, 60% of the age standardized death rates were attributable to risk factors, and this value is of 40% for daily rates. And there was a decrease on both death and daily rates attributable to risk factors. Here you can see some of the leading risk factors on both actually on daily rates, so both females and males, and you can see that the leading risk factors are tobacco and high blood pressure. Actually, you can see that for instance the second cause and second risk factor for males is alcohol use, while this is only the sixth risk factor within females. So some differences between both sexes, of course, and we have to consider these for tackling these different risk factors. Same kind of figure here for risk factors, and same kind of pattern, of course, that because it is ranked by the age standardized daily rates for all risk factors. Here, the first column, and you can see that some countries are well above the European Union average, while some others are well below, like Italy, Sweden, Spain, or France. And again, we can highlight some important things like the high impact on age standardized daily rates for tobacco in Greece, Croatia, and Poland, for instance. We can also highlight, for instance, in Portugal, the high value of daily rates regarding unsafe sex and the drug use, for instance, also here in Finland. So some remarks that we can conclude from here, but afterwards I hope that you can see this in the paper that should come in the coming months. So here you just have only the death rates, so the age standardized death rates, and the x-axis you have actually the rate, and in the y-axis you have the change between 2010 and 2019, and you can see that regarding the death rates, there is mainly a decrease between these both years that we are considering in all the risk factors, mainly if you look the one that is clearly on the lead is air pollution, as you can see. And in the next figure, and here you can see the same, but for summary exposure value. So this meaning that is somehow a prevalence thing. And you can see the same for air pollution, so leading the decreases, but actually we can see, for instance, that low physical activity and dietary risks, for instance, seem to be increased between this period that we are considering, and actually high fasting plasma glucose increased a lot, so about 15% between these 2 years. Finally, regarding the daily rates, so the age standardized daily rates, same thing for air pollutions. We can see that tobacco still leads on the impact on daily rates, but we can see that there are no clear increases, rather than childhood sexual abuse and bullying coming mainly from YLDs, of course. And this should be something that we should look after and try to actually reduce through health interventions, of course, in different countries. And as of conclusions, we can see that there, of course, there is a decrease. There is still a east-west gap, as well as in the state of health that I presented before. Significant decreases of air pollution-related burden of disease. However, important increases regarding metabolic risk, for instance, high fasting plasma glucose, and we should indeed try to implement this kind of evidence-based policies or interventions to tackle these not so good news regarding the metabolic risks. And there are also limitations in these estimates, so several risks are not included in analysis. For instance, we are not considering social determinants of health, and again, same disability weights and same severity distributions, and relying, of course, on the data. And that's it from me.
Yeah, perfect. Thanks once again, Zhao. So we again have time for a number of questions or comments from the audience. So please feel free to use the Q&A box to add your questions. Okay, we have a question here. So the question is, does focusing on these individual level factors would let wider risk factors that influence social and environmental risk off the hook? So for instance, government imposed austerity policies that have cut funding to public services. So the risk factors included in the GBD are individual level risk factors, behavioral, metabolic, okay, the environmental are already a bit broader, but then you have the more distal risk factors such as the social environment and the political environment that of course also affects, and maybe even more so, the health state of a population. So isn't there a risk, at least in perception, that by not having included these distal risk factors that we might get the perception that everything is the fault of individuals and that governments don't have an as important impact on population health as they might have?
Yeah, so thank you so much for this interesting question. I think that first of all, we have to consider that even in the individual level risk factors, this is a joint work between the population, so all of us, and actually the government. So actually, also the governments should play a role also there, not only the individuals. That's why there are public health institutes and such things and health interventions so wider in terms of healthcare. However, as I said, we are not including social determinants of health, and this should mean, or at least means that this kind of information that should or could be included in further analysis might be done. And more than that, I have to say that, of course, when we are trying to get a proportion of the daily rates, for instance, that are attributable to risk factors, we are, of course, underestimating a lot, because so we have social determinants of health, we have so many kind of potential risk factors that are not included here, but at least this is a starting point to tackle some of the risk factors. For instance, tobacco, which is a thing that clearly the European Union and the European Union countries are trying to deal with, and with different policies. And here, with this kind of analysis, we can explore who are doing better, who are doing worse, and what are, for instance, the countries that can share the best practices and who are performing better on that field.
Okay, great. Thanks a lot. And always when talking about individual risk factors and behavioral risk factors, as you mentioned, I think it's very important to stress that this is not the same as putting the responsibility only on the shoulders of the individuals, because a large part of our behavior is influenced by our surroundings, by how governments, but also industries try to influence us towards bad behavior. So this is something that we should always mention when talking about behavioral risk factors, that this behavior is something that is being influenced and for which population health institutes can play an important role in balancing the negative influences that come from industry and other main actors. So thanks for the question, and Jiao, thanks a lot for your insights and for the discussion. One of the overarching conclusions of the two presentations was that the East-West divide is still there, is visible in almost all the indicators that we have access to. And this topic of inequalities across Europe will be explored in more detail in the next presentation, which will be given to us by José Luis Peñalvo from the Institute of Tropical Medicine in Belgium. And he has led a collaborative work where the estimates from the GBD study have been used as inputs for additional calculations on inequalities in health across Europe. So I will now give the floor to you, José, and then you can go ahead with your presentation. Thank you.
Thank you so much, Jeff. And thanks to the European Burden of Disease Network for the opportunity to present this paper, and to all of you that are attending the session. So following the presentation of my colleague, João, I would like to introduce the main results of a recent paper that we have developed to characterize the inequalities in non-communicable diseases across the EU members, the current state in 2019, and also the trends over the last 20 years. So as you have already heard, NCDs are there, and their risk factors represent a major burden on the economy and the health of the European Union. However, this burden is not homogeneous across the EU, and there are variations that are driven by several factors, including geography, so differences between countries, demographics, socioeconomic status, risk factors, as you have heard, and urban and rural settings. And these variations, of course, can drive inequalities in health that are very important to address. EU governance at all levels have encouraged member states to act by implementing intersectorial actions focused on risk factors, disease prevention, and healthy aging, and including in-depth explorations of inequalities among vulnerable populations, and also to provide technical support for public policies. These actions, together with active surveillance systems of risk factors and NCDs, as well as investments at the national and local levels, should have helped decreasing the burden of inequalities in Europe. So based on these premises and these previous ideas, we sought to explore what is the burden of inequalities related to non-communicable diseases, so the more burdensome conditions in the EU, and how it might vary across the different countries and different economies across the EU, and to further understand if the disparity or the inequality gap has been narrowing or increasing during the last 20 years. To do this, we have used data from the global burden of disease, as in the two previous papers, between the years 19 and 2019. And we extracted data for prevalence, mortality, and disability-adjusted life years in rates per 100,000. From the available list of causes that are available to GDD, we use the overall one category, so for the overall non-communicable diseases, 12 causes for level 2, and 8 selected level 3 causes that we have chosen based on the mortality numbers. So the causes that cause, the diseases that cause more mortality throughout Europe. We also structured the socioeconomic status information that is given by the socio-demographic index. And we also used data from the World Bank to extract population numbers and gross domestic product that is used in the analysis. We used country-level data for 28 countries that were conforming the EU in 2019. So we used the following stratifiers representing potential disparities that were recommended by the WHO: geography, as in countries, gender, and socioeconomic measures represented by the SDI, which is a composite indicator of development, and that is quite correlated with health outcomes, and accounts for fertility, education, and income. And it ranges from 0, that's the minimal level of the indicator, to 1, that will be the maximum, as well for GDP that is used in the normal way. Okay, so for the estimation of disparity, we used a number of different metrics, because there's no a single standard standard metric to be used. We use simple indicators, only the values of the two countries representing the extremes between the burden, either in absolute numbers or relative numbers, as well as population weight metrics that again represent the absolute or the relative differences between extremes, but they do account for the whole European population. And we have also used population attributable fractions to calculate the fractions that could be, the population fractions that could be averted, or the proportion of the burden that could have been averted if the extremes of the distribution would have been pushed to the average mean in Europe. So I'm going to focus mostly on the relative index of inequalities, because in my eyes is the most precise metric to be used. This metric is calculated through a regression-based procedure that quantifying the gradient indices rates in a relative scale. I won't go too much into these details, sorry. I will just go, for the sake of time, to the results. So the mortality for attributed to non-communicable diseases is still high in the European Union. It was around 415 in 2000. Sorry, it is at 415 in 2019, but it has been decreasing since the year 2000, about 25% on average. However, as you can see in the slide, the decrease is not homogeneous across the countries, and is generally lower for Central and European countries. And there is also not a clear distinction between females and males, so left and right on your slide. Looking at the mortality rates in numbers, Bulgaria is consistently presenting the higher rates of mortality, and France the lower rates. And according to the measure of inequality, about 2 times higher, one respective to the other, with this relative difference being persistent over the last 20 years. So no changes have been observed. Moving to DALYs, so considering simultaneously premature death and disability, this metric shows again a similar overall decrease since the year 2000, about a 15% of average, and again with no distinctive pattern driven by sex. By countries, again, Bulgaria is the worst off country in the EU 28, and the least burdened country was Sweden, and currently is Slovenia. The magnitude of the disparity, as you can see by the relative inequality index, is smaller than for mortality, and there is a trend towards reducing the disparity in this particular metric. Across selected level 3 causes, the relative index of inequalities for the DALYs rate was and remained as of 2019 the highest for ischemic heart disease, about almost 8, and for stroke almost 7, with Bulgaria again and France being on the extremes, followed by cirrhosis, extremes being Romania and the Netherlands, and followed again for COPD between Denmark with the highest and Latvia with the lowest. And as you can see, there is a bit of a trend towards decreasing the magnitude of the disparity for the major conditions showing more disparity, so for stroke and for ischemic heart disease. Then, looking at inequalities that arise from differential socioeconomic status, there are clear disparities in the burden of ischemic diseases, when compared with different countries with different SDIs or GDP numbers. As both stratifiers, as you can see, SDIs are in red, GDP are in blue. Both stratifiers give very similar estimates. From this slide, you can also see how for some conditions, such as chronic obstructive pulmonary disease or osteoarthritis, the condition is, the association is inverse, meaning that higher burdens are observed among countries with higher socioeconomic indicators. Right, so this is just to summarize a little bit all the different conditions. I cannot see too well. As you can see, the trends related to disparities driven by socioeconomic status are overall stable or decreasing in some instances, but in general they are all remaining the same. So this is in my opinion, a major point of focus for future policy. Right, so some conclusions. So since the 2000, NCDs are the most prevalent and burdening group of diseases in the EU 28, despite existing strategies to tackle NCDs in Europe, there are quite a lot of ongoing policies. They seem to be insufficient when it comes to balance or decrease the disparity gap. While the inequalities are apparent, the disparity gap differs depending on the metric used. They're more pronounced for mortality, but a little bit less pronounced for deaths. And the burden of ischemic diseases, both heart disease and cerebrovascular diseases, are particularly variable across the EU, representing geographical and socioeconomic disparities in access and CVD prevention and care. Yeah, and the outlook and the future steps is, as has been discussed before, this will be probably an inflection point when it comes to inequalities. Both because of the current pandemic, but also because of Brexit. And these two situations will greatly influence the disparity gap, normally to wider magnitudes. And we hope that this information that we will provide in this paper could serve as a benchmarking for future assessments of inequalities in Europe and elsewhere. So I'd like to thank again the network of the assessment of burden of disease in Europe and all the collaborators that have participated in this analysis. Thank you.
Okay, perfect. Thanks a lot, Jose, for these very interesting results, very important results as well. Giving us a lot of details on how inequalities prevail and persist within the European Union. We again have some time for questions and answers. We have around 10 minutes remaining. So please take your time if you would have any questions to add them to the Q&A box. Maybe in the meantime, one thing that struck me when you showed the maps of mortality and DALY rates across Europe. For the mortality rates, the east-west gradient was a lot more evident than for the DALY rates. And where in the DALY rates, you also saw UK and Germany having a darker red color. So would you have any thoughts on why the east-west gradient is more important for mortality than for overall DALYs?
Yeah, I don't have a clear explanation really, but it might be, of course, something related to access of care and access of health system resources for sure. But I don't have a clear explanation.
Yeah. Okay. maybe also some links with one of the findings you showed at the end of, for instance, osteoarthritis, which doesn't show the same patterns, or maybe not. Yeah.
Yeah, for osteoarthritis, I'm not quite sure what would be the drivers, but for example, this inverse association for COPD, that makes a lot of sense. So the more advanced, economically advanced countries, may have a higher burden of this condition. For osteoarthritis, that's something we need to look more into detail.
Yeah. Okay. Thanks. So if anyone from the audience would have any additional comment or question, feel free to make use of the time that we have for this now. Or any questions for Joao, so we can have a group discussion if needed. Yep. Okay. I'm not seeing any more questions popping up. In any case, if you want to stay informed about the future steps in these analyses and these publications, then don't hesitate to follow the European Burden of Disease Network via our website or social media channels, or by becoming a member of the network if you're not yet a member. If there are no further questions, then I suggest we can conclude this session, if that's okay for you, Jose and Joao.
Sure, thank you.
So also from my side, thanks a lot to the two of you for your very clear presentations and a nice discussion. And we look forward to the next steps in these activities and future insights. So thank you all very much. Also thanks to the attendees, of course, and we look forward to seeing you in our future workshops and activities. So thanks everyone, and have a very nice day. Thank you.
Thank you so much. Bye-bye.
Thanks.